It's generally known that there exist two types of diabetes. Diabetes type number 1, which make up about 5% of the population, and type 2 diabetes, which make up more than 90% of the population, the diabetic population. So while the type number 1 is very homogeneous, type 2 diabetes is very heterogeneous, very different people, thin, thick, and so forth. In the meantime, a Scandinavian group analyzed 15,000 newly diagnosed diabetic people and clustered them into 5 different clusters. And this is important because it turned out that these different clusters, which are based on laboratory parameters and age of diagnosis and BMI, that they turn out to progress differently in diabetes, hyperglycemia, and also to late complication. So for example, cluster 2, which needs insulin for treatment and has very high hemoglobin A1C, that is much prone for diabetic retinopathy, the eye disease, while cluster 3, which is prone to diabetic nephropathy, has decent hemoglobin A1C, so the blood sugar is not that high, but they're very resistant to insulin. And the colleagues say that they should be treated differently, which is not true in praxis, in normal practitioners, because cluster 2, prone for diabetic retinopathy, is very often treated with oral antidiabetics, but they should be treated with insulin. And the other way around, the cluster 3, prone to diabetic nephropathy, they are treated with insulin and others, but they should be treated with metformin, a very different drug. So this is one important result for the diabetes community, the doctors, and all these results are replicated in other cohorts in the world, and also has been replicated in China and India. They find the same, and in Great Britain. So it's a big discussion now in the community, and we are looking forward for the new outcomes. Thank you.
Thank you.